laboratory.
I can picture it.
It's quiet, sterile, the lighting is crisp and bright. You can see rows of microscopes on the benches, and sitting on the shelves are those complex molecular models. You know, the ones, the spiky little spheres that look like something out of a sci-fi movie.
It's a fitting backdrop because where we are going today is strictly clinical, it is precise, it is microscopic, and frankly, the stakes couldn't be higher.
Exactly. The topic is one that I think every single person listening recognizes instantly by name. It's a word that defined a generation, changed culture, and rewrote the rules of sex and medicine. We are talking about HIV.
Human immunodeficiency virus.
But here's the thing, and the reason I wanted to do this deep dive today, I feel like most of us know let's call it the after-school special version of HIV. We know the fear, we know the history, but we don't know the mechanics.
That's a very common gap. It's a term that carries so much weight, political, emotional, historical, that the actual science often gets lost.
Right.
People know it's a virus, but they don't know the war map. They don't know the strategy.
That is exactly what I want to strip away today. I want to look at the data. I want to understand how this virus actually gets in, how it hijacks the system, and most importantly, what this massive high-tech arsenal of pharmacological weapons is that we've developed to pin it down.
And that is a fascinating story. It's not just a story of a disease, it's a story of medical strategy. We aren't just looking at a pathogen, we are looking at a chess match between human biology and a virus that is, well, incredibly adaptable.
So lay out the source material for us. What are we working with?
We have a comprehensive set of clinical chapters and medical texts. We were looking at etiology, which is the cause pathogenesis, which is how the disease develops, and we have a very heavy focus on pharmacologic therapy and opportunistic infections.
So this is the playbook.
This is effectively the playbook that doctors use.
Yes. The playbook. I like that. And I promise, listener, we're going to keep this accessible. You don't need a medical degree to follow this, but we are definitely going to go deeper than just wear a condom. We want to understand the why.
Though, as we will see, wearing a condom remains excellent advice based on the physics of transmission.
Spoiler alert, but yes, let's get into it. The mission is to demystify the clinical complexity. We're going to look at the invader, the defense, and the arsenal.
Shall we start at the gate? How the virus enters the system.
Let's do it. Segment 1, the invader and the defense. We have to talk about transmission dynamics. Now, if you ask the average person how HIV is transmitted, they'll give you the big three.
Sex, needles, and mother to child.
Which the clinical texts classify as sexual, parenteral, and perinatal.
Exactly.
But looking at the data, there's a lot of nuance inside those categories. Let's look at sexual transmission first. The source material makes a very sharp, specific distinction between vaginal and anal intercourse.
And this is not a moral distinction, it's purely biological.
Well, it's about anatomy.
It is entirely anatomy. The probability of HIV transmission from receptive anorectal intercourse is significantly higher than vaginal intercourse. The data suggests a risk range of 0.5% to 3% per sexual contact.
I want to pause on that number, 0.5% to 3%. Because if you just hear it quickly, you might think, oh, that sounds low. That's a 1 in 200 chance at the low end. But in the world of infectious disease, that is actually surprisingly high for a single contact, isn't it?
It is very high efficiency. And to understand why, you have to look at the terrain. The rectal mucosa, the lining of the rectum, is very different from the vaginal lining.
Oh, so?
It is composed of a single layer of columnar epithelial cells, just one layer.
So it's fragile. It's not designed for, well, for friction.
Exactly. It is designed for absorption, so it tears easily during intercourse, often microscopically. You wouldn't even know it's happening.
And right under that surface.
Right underneath that thin single layer is a rich supply of blood vessels and immune cells, specifically the CD4 cells that HIV is programmed to target.
It's essentially providing a direct on-ramp to the bloodstream. You're opening the door and pointing the virus right to its favorite food.
Precisely. Now compare that to the vaginal mucosa, which is multi-layered squamous epithelium. It's tougher, more like skin.
A much better barrier.
A much better barrier. It's designed to handle friction and bacteria. It's not impenetrable, but the risk is statistically lower.
That explains the disparity. But then the source introduces this concept of cofactors. It's not just about the act itself. It's about the environment the virus lands in.
Right. This is the why behind the increased risk. The source highlights that the presence of other sexually transmitted diseases, syphilis, herpes, chlamydia, creates a gateway.
Is that just because of, open sores, like a physical break in the wall?
That's part of it, a big part. Think of a syphilitic chancre or a herpes ulcer as a physical breach in the castle wall. It's an open door,
Makes sense.
but it's also about inflammation. This is the subtle part. When you have an infection like chlamydia, your body does what it's supposed to do. It sends immune cells to that area to fight it.
And let me guess, those immune cells are the CD4 cells.
The very targets HIV is looking for. So by having another STD, you aren't just opening the door, you are rolling out the red carpet and gathering a crowd of victims for the virus to infect.
Wow.
It's a cascade effect, a cruel irony.
It really is. The body's attempt to fight one infection actually makes it easier for HIV to take hold. Now let's move to the second mode, parenteral. This is needles.
Injection-related paraphernalia, yes. Historically, this has been a major driver of the epidemic.
And it's so efficient because you're just bypassing everything.
You're bypassing all the body's natural barriers, skin, mucosa, stomach acid, and you are injecting the virus straight into the circulation. It's the most direct route possible.
What about the healthcare worker scenario? We see it in movies all the time. The surgeon gets pricked by a needle during an operation.
It happens. We call it an accidental percutaneous needle stick injury, but the risk is statistically quite small compared to the other modes. Yes, the amount of blood is tiny. The virus may not be present in that drop. It's definitely a risk, and it's terrifying for the person involved, which is why we have protocols like Pilecki, which we'll get to. But it is not the primary engine of the epidemic.
Okay. And the third mode, perinatal, transmission from mother to child.
This is one of the most emotional aspects of the disease. Without medical intervention, the source is clear. The risk of a mother passing HIV to her child is about 25%.
1 in 4. That's staggering.
It is, and that transmission can happen during pregnancy, across the placenta, during the trauma of labor and delivery, or through breastfeeding.
A lot of opportunities.
But hold on to that 25% number, because later, when we talk about the pharmacological arsenal, we'll see how drastically we have managed to change that statistic. It's a real success story.
Okay, pin place. So the virus is in. It has crossed the moat. What happens next? The source talks about the acute phase.
This is the initial reaction. The body realizes something foreign is there, and it mounts a general defense. We call it viral syndrome.
And the symptoms listed here: fever, pharyngitis, which is a sore throat, adenopathy, swollen glands, and maybe a rash. It sounds exactly like the flu. Or maybe mononucleosis.
That is the deception. A patient might just think they caught a bad cold or a seasonal bug. These symptoms usually last about 2 weeks and then resolve on their own.
They just go away.
They go away. The body gets the initial situation under some control, but here is the dangerous part: the window period.
This is the concept that always confuses people regarding testing. Walk us through this.
So most standard HIV screening tests, the ones you'd get at a clinic, are looking for antibodies.
The soldiers your immune system builds to fight the specific invader.
Right. But it takes time for your body to recognize the threat and manufacture those specific antibodies. It's not instant.
How long? What are we talking about?
Usually 3 to 4 weeks, sometimes longer. So imagine a timeline. You get infected on day 1. By day 14, you have a fever and a very high viral load. You are incredibly contagious at this point.
Okay.
But if you go and take a standard antibody test, it comes back negative.
That is terrifying. You were walking around with a negative test result, thinking you were safe, maybe changing your behavior based on that, but biologically, you are a super spreader.
Exactly. The virus is replicating unchecked. And that replication brings us to the most critical concept in understanding how we manage this disease: the numbers game.
Right.
We have 2 main players on the scoreboard.
The CD4 count and the viral load.
Correct. The defense and the offense.
Let's unpack these, because if you talk to anyone managing HIV, these are the metrics that dictate their life. First, the CD4 cells. The defense.
These are the CD4 T lymphocytes. You can think of them as the generals of the immune system.
They call the shots.
They do. They don't just fight infection themselves. They direct the traffic. They tell the rest of the immune system what to attack, when to attack, and how hard.
So what's a normal number?
In a healthy person without HIV, you want to see a count somewhere between 500 and 1,600 cells per cubic millimeter.
So 500 is the floor for normal, and then we have the viral load, the offense.
Right. This measures the amount of HIV RNA copies in a milliliter of blood. It tells us how fast the virus is reproducing. Are we looking at a small campfire or a raging forest fire?
And there was a statistic in the source material that really stopped me in my tracks. It showed the correlation between these numbers and mortality before effective treatment. It wasn't a subtle difference.
It's a stark gradient. The data looked at 5-year mortality rates. For patients with a viral load less than 4,530, the 5-year mortality was only 5%.
Which is very manageable. even then.
Very. But for those with a viral load greater than 36,276, not even 10 times higher, the mortality rate jumped to 49%.
That is nearly a coin flip, 50-50,
Yeah.
based on the amount of virus in the blood.
It underscores the entire philosophy of treatment. Keep the viral load down. If you keep the viral load down, the CD4 count stays up and the patient lives a long, healthy life. It is a direct seesaw relationship.
And if you don't keep it down, that's when we cross the line into AIDS. I think in pop culture, HIV and AIDS are used almost interchangeably, but they're technically very different clinical stages.
Very different, and it's an important distinction. HIV is the virus. AIDS-acquired immunodeficiency syndrome is the collapse of the system.
It's the end stage.
It is defined as stage 3 of the infection, yes.
What is the specific threshold? How do you know you've crossed that line?
We define AIDS when the CD4 count drops below 200. Remember, normal is above 500. So at 200, your immune system is severely weakened.
So it's a numbers game.
It's a numbers game, or if the patient develops what we call an AIDS-defining condition,
which we will get into in segment 4. These are the diseases that only show up when the walls are down.
Exactly. Things like candidiasis in the lungs, not just the mouth, or Kaposi sarcoma. If you see those, it's AIDS, regardless of what the CD4 count is at that moment.
It is a grim picture. But, and this is the whole point, we are not living in the 1980s anymore. We have tools. And that brings us to segment 2, the arsenal.
Pharmacologic therapy. This is where the science gets truly incredible.
The source outlines a singular overriding goal for treatment. What is the mission statement here?
Maximum suppression. We want the HIV replication to be so low that our tests can't find it. We want it to be undetectable.
Undetectable. That is the holy grail.
It is. Because if the virus isn't replicating, it isn't killing CD4 cells, the immune function can then restore itself.
The CD4 count goes back up.
Right. And, crucially, it prevents transmission to others.
So how do we do it? The source describes a strategy that reminds me of a military siege. We don't just send one soldier, we send a squad.
It's called combination therapy, or antiretroviral therapy art. And the analogy is perfect. Imagine the virus is a master locksmith. If you try to lock it out with just one drug, it will eventually figure out the key.
It mutates.
It mutates. It evolves resistance. HIV is an RNA virus, and its replication process is sloppy. It makes a lot of mistakes.
And some of those mistakes, by pure chance, happen to make it immune to the drug you're using.
Exactly. But if we hit it with a minimum of 3 active agents simultaneously blocking 3 different doors at once, the statistical probability of the virus mutating enough to escape all 3 traps at the same exact moment is infinitesimally small.
We overwhelm its ability to adapt. So let's get like the menu, the drug classes.
Oh.
This is where it gets a little technical, but I love this part because it explains the mechanism. We are targeting specific steps in the virus's assembly line.
Let's walk through the factory floor. First, the virus has to get into the CD4 cell.
Right, the front door.
So we have entry inhibitors. These are the bouncers. They essentially board up the windows or jam the keyhole. They stop the virus from docking with the CD4 cell and getting inside.
Access denied.
If it gets in, the virus, which is an RNA virus, needs to write its genetic code into DNA so the human cell can read it. It's like translating a foreign document.
Okay.
It uses an enzyme called reverse transcriptase to do this.
So we have reverse transcriptase inhibitor.
We do. There are 2 main types, NRTIs and NNRTIs. Think of these as sabotaging the photocopier. The virus tries to write its code, but the drug inserts a piece of gibberish, a fake building block, and the whole process jams. The copy comes out corrupted and useless.
The source mentions tenofovir and intricidivine here. These seem to be the heavy hitters.
They are the backbone of most modern regimens. Very effective, very well tolerated.
Okay, so let's say the virus somehow gets its code written. What's next?
It needs to file that code into the human DNA library, the nucleus.
Our own genetic code.
Yes. It wants to become a permanent part of the cell's blueprint. It uses an enzyme called integrase to do that.
So naturally we have integrase inhibitors.
The NSTIs. These are incredibly effective. They stop the virus from integrating its DNA into the host. It's like stopping a spy from filing a fake blueprint in the master archive. If it can't file the blueprint, the factory never gets built.
I love that analogy. And finally, if it manages to do all that and the cell starts making new virus parts, what's the last step?
Those parts need to be assembled. They come out as long, non-functional protein chains. An enzyme called protease acts like a pair of scissors, cutting those chains into the final functional viral units.
So we have protease inhibitors.
PIs, they gum up the scissors. The virus might produce raw materials, but they can't be assembled into a finished product. The new viruses are immature, clunky, and they don't work.
It's a total dismantling of the life cycle at every single critical step. Now, putting this into a cocktail, the source talks about a preferred recipe.
The standard of care has evolved, but it usually involves two NRTIs, like the tenofovir and emtricitabine we mentioned, plus a third agent from a different class.
Like what?
Very often nowadays, it's an integrase inhibitor, or sometimes a boosted protease inhibitor.
I want to touch on that word, boosted. The source mentions a drug called ritonavir, but it's not just there as an antiviral, it's there to manipulate the liver. This seems wild to me.
This is fascinating pharmacology. Our livers are very efficient at cleaning toxins and drugs out of our blood. They have a whole system for it.
Right, the cytochrome P450 enzyme system.
Exactly. Ritonavir at low doses inhibits that system. It slows it down.
Wait, so we are intentionally hobbling the liver?
In a targeted way, yes. By slowing down the liver's trash disposal, the levels of the other HIV drugs, the protease inhibitors, stay higher in the blood for much longer.
So you get more bang for your buck.
You do. It boosts their effectiveness. It allows for lower doses of the main drug and easier dosing schedules, maybe once a day instead of 3 times.
That is so clever. It's using a side effect as a main effect. But this whole elegant system relies on one thing: the patient actually taking the pills every day.
Adherence is everything. The regimen is strict. The source notes that therapeutic failure is most often due to non-adherence. You cannot miss doses.
Because if you drop the pressure, even for a day or two, the virus wakes up.
And it mutates. The few viral copies that survive might be the ones that have a random resistance. You're essentially selecting for the toughest ones.
Now, how do you know if it's working?
You watch the numbers. If the viral load isn't suppressed, we look for a significant drop, usually a log reduction or a 10-fold drop within 1 to 4 weeks. We know something is wrong.
And it could be one of two things.
Right. Either the drug combination isn't working against that particular viral strain, or the patient isn't taking it correctly.
And it's resistance. If the virus has outsmarted the drugs,
then we have to change the strategy. We do resistance testing, we sequence the virus's genes, and we look at the menu again, pick a new combination it hasn't seen before.
it's a constant vigilance. But speaking of vigilance, it's not just about the HIV drugs. It's about everything else the patient puts in their body. This brings us to segment 3, nuance and interactions. The fine print.
This is where it gets tricky for general practitioners and why HIV care is so specialized. Because these drugs interact with that liver enzyme system we just talked about, adding other substances can cause chaos.
The source specifically flags St. John's wort. Now, that's something people just buy at the health food store to help with their mood. It seems totally harmless.
It seems harmless, but St. John's wort is a potent inducer of that P450 system.
Wait, an inducer, so the opposite of ritonavir.
The exact opposite. Remember how ritonavir slowed down the liver? St. John's wort revs it up. It puts the trash disposal into overdrive.
Oh, no.
If you take St. John's wort while on many HIV meds, your liver basically eats the HIV drugs too fast. Their levels in your blood drop, and suddenly it's not effective anymore.
The virus has an opening?
The virus has an opening to replicate and mutate.
A cup of herbal tea could theoretically ruin your entire therapy. That's wild.
It is. Another major conflict is a drug called rifampin.
What's that for?
It's a key drug used for tuberculosis, and it has a similar inducing effect. It clashes violently with protease inhibitors. Since TB and HIV often occur together in what we call a co-infection, this is a massive clinical headache.
You have to treat both, but the treatments fight each other.
Right. It requires very careful drug selection and management.
Let's pivot to a different kind of nuance: pregnancy. We mentioned earlier that untreated risk is 25%. What is the protocol now? How do we stop that?
The standard is clear and has been for a while. Women receive optimal antiretroviral therapy regardless of their pregnancy status. We treat the mother aggressively to protect the child.
So you don't reduce the dose or anything like that?
No, the goal is the same. Get the mother's viral load to undetectable. An undetectable viral load is the best protection for the baby.
And there's a specific protocol for labor, right?
Yes. Often an IV infusion of a drug called zidovudine is administered during labor itself. This is when the risk of blood mixing is highest. It provides an extra layer of protection right at the critical moment.
And after the baby is born, is that it?
No. Once the infant is born, they get 6 weeks of prophylactic medication themselves, usually a liquid form of zidovudine.
So you're protecting from all angles.
Exactly. And the result, the therapy drastically reduces transmission. We've gone from that 25% tragedy to a risk that is less than 1% if these guidelines are followed properly.
It's one of the great public health victories of our time.
It truly is.
Now, what about the other side of exposure? Let's say you aren't HIV positive, but you have a high-risk event. A needle stick at work, a condom breaks with a partner whose status is unknown or positive.
That's PEP, post-exposure prophylaxis.
The emergency brake.
The emergency brake is a good way to put it. But the clock is ticking, and it's ticking very fast.
How fast?
Ideally, you want to start PP within 1 to 2 hours of the exposure.
1 to 2 hours. That is an incredibly tight window.
It is. The recommendation extends up to 72 hours, but every hour counts. The sooner you start, the better the chance of success.
And why is that? What's happening those first hours?
You are trying to stop the virus before it establishes a permanent foothold. Before it gets into the lymph nodes and sets up what we call a latent reservoir, you're trying to extinguish the fire before it spreads from the kindling.
And it's not just one pill.
No, it's a full 4-week course of a triple drug regimen. It's essentially a short, intense course of full-blown HIV treatment to prevent the infection from ever taking hold.
So we have the tools to prevent it, and we have the tools to suppress it. But what happens when the defense cracks? Segment 4. When the treatment fails, or when a person doesn't know they are infected until it's far too late?
This brings us to the opportunistic infections.
OIs. The concept here is chilling. These are infections that are essentially lurking in our environment or even in our own bodies, just waiting for the guard to fall asleep.
They are organisms that a person with a healthy immune system encounters every day without any issue. Our immune system handles them silently in the background. But when the CD4 count drops, they strike.
The big one mentioned in the source is PCP, Pneumocystis jirovecii.
It's a fungus, and it causes a severe pneumonia. It's the most common, life-threatening, opportunistic infection in people with AIDS.
And the source describes its onset as insidious. That phrase stuck with me. It doesn't hit you like a truck overnight.
No, it creeps up over weeks. A low-grade fever that won't go away, a persistent dry cough, and something called tachypnea, rapid, shallow breathing. The patient is starved for air, but there's no phlegm.
And the treatment?
The go-to is a combination antibiotic trimethoprim sulfamethoxazole. You might know it by the brand name Bactrim.
That's a common antibiotic. I think I've had that for a sinus infection.
Common, yes. But for treating active PCP, we use a very, very high dose. And there's a critical nuance the source highlights.
Where it's at.
If the patient is hypoxic, if their oxygen levels in their blood are low, we don't just give antibiotics, we add glucocorticoids. Steroids.
Why steroids? I thought that's the last thing you want to do, suppress the immune system even more.
It seems completely counterintuitive. But the danger in severe PCP is often not the fungus itself, but the massive inflammation in the lungs as the body tries to fight it.
The friendly fire.
It's the friendly fire causing respiratory failure. The steroids calm that storm just enough to keep the patient breathing while the antibiotics do their job and kill the organism. It saves lives.
It's a delicate, dangerous balance. Now, we talked about the CD4 numbers, 500, 200. The force lists some magic numbers for prevention. Prophylaxis.
This is proactive medicine. We don't wait for the infection to happen. We treat based on the CD4 count to prevent it.
So if the CD4 count drops below 200?
We start meds for PCT, usually that same Bactrim, but at a much lower preventative dose, once a day or 3 times a week.
You just assume the risk is too high and you pre-treat. And if it drops below 100?
Below 100, another villain enters the picture. We have to watch out for Toxoplasma gondii.
I've heard of that. It's from cats.
It can be, but it's also in undercooked meat. In a healthy person, it's a nothing burger. In someone with a CD4 count under 100, it can cause toxoplasmosis, which often presents as encephalitis brain inflammation with ring-enhancing lesions.
And below 50, this is the real danger zone.
Below 50, the immune system is severely compromised. We start prophylaxis for MC Mycobacterium avium complex.
That sounds related to tuberculosis.
It's in the same family, but it's a different bug. It's ubiquitous in the environment, in soil and water. For someone with a CD4 count of 25, it can cause a disseminated infection throughout the body. High fevers, wasting, night sweats, it's devastating.
It really emphasizes how structured the decline is.
Yeah.
It's not random. The lower the number, the more villains enter the stage.
Which is why the viral load and CD4 monitoring is so vital. We can see these milestones coming from a mile away and intervene before they happen.
The source also mentions a few other villains. Candidiasis thrush.
Very common. People might know it as a yeast infection. In this context, it often presents as thick white patches in the mouth and throat. It's a clear signal the immune system is struggling.
Cryptococcal meningitis.
That's a fungal infection of the lining of the brain. It causes a terrible headache, fever, and requires powerful, often toxic IV antifungals like amphotericin B.
And CMV retinitis.
Cytomegalovirus, another common virus that most of us carry without symptoms. But in this setting, it can attack the retina in the back of the eye. It can cause blindness if not treated.
It's a laundry list of misery. But, and this is the important part, it is all preventable.
It is entirely preventable if the HIV is treated effectively. If you keep that viral load undetectable and the CD4 count high, these opportunists never get their chance.
So let's bring this home. We've covered a lot of ground today. From the 0.5% risk of transmission to the molecular machinery of integrase inhibitors to the 72-hour window for PP.
It's a complex landscape, but if we zoom out, the story is, well, it's remarkable.
Summarize it for us. What is the big picture here?
The big picture is the shift. We have moved from a time when an HIV diagnosis was a certain, often rapid, death sentence, to a time where it is a chronic, manageable condition.
Manageable, like diabetes or hypertension. You have to take your meds, you have to see your doctor, but you can live a full life.
Provided one adheres to the rigorous science of viral suppression. The virus enters, the immune system fights via CD4, we track the score with viral load, and we deploy this massive arsenal of ART and antiretroviral therapy. We watch for the opportunists, and we block them before they can strike.
It's a triumph of science, really, a testament to decades of research. But the source leaves us with a final, slightly provocative thought. And I want to end on this because it keeps us grounded.
It does. The text explicitly mentions that even with viral loads below detectable limits, patients should be considered infectious and counseled on risk reduction behavior.
Now, I know there's a lot of modern discussion and newer data about undetectable equals untransmittable, and that has become a major public health message.
Yeah.
But our source material here is very cautious.
It's a bit more old school, a bit more conservative in its recommendation.
It says if the drugs are so potent they make the virus invisible to our best tests, what does it imply about the nature of the virus, that we still must act as if it is fully present?
It implies a sleeping giant. The virus isn't gone, it's just pinned down. It's in a latent state in certain cells. It suggests that the nature of HIV is one of incredible persistence.
That's always waiting.
It is always waiting for a missed dose, for therapy to stop, to wake up and start the whole process over again.
It's a reminder that while we have the upper hand, we haven't won the war. The enemy is just in a holding cell.
A holding cell built of molecules and daily discipline.
An incredible deep dive today. I feel like I understand the mechanics of this so much better now.
It's always in the details, isn't it?
Thank you all for listening. Stay curious, stay informed,